what this panel is focused on is crowdsourcing innovative solutions across government and industry, and that's a very generic term. I'm Sean Mannion. I'm your host for this dialogue. I will briefly introduce our panelists, but let them give a 30 to 60-second introduction before we jump into what is a very exciting moment, because FDA is here with precisionFDA, and VHA had an innovation ecosystem COVID-19 risk factor modeling challenge, and they're going to announce their winners here today. So that's really exciting. But to start, we have Dr. Jorge Ferrer, we have Debbie Bucci, and we have Elaine Johanson from the FDA. Dr. Ferrer is from the VA. Debbie Bucci is former Health and Human Services NIH Office of National Coordinator. She is retired and come to work on the industry side now, and she has a wealth of knowledge. And with that, I will let each of our panelists give you a little more background about where they're coming from with respect to innovation in public or private sense. So, Dr. Ferrer?
Hi, Sean. Can you hear me?
Yes.
Beautiful. This is actually my first live Zoom meeting, so this should be interesting. Jorge Ferrer, VA medical informatician. I work in the medical informatics side of the VA, and I work in the Office of Technical Integration, the VIC, which is the VA Innovation Center. I have been working in informatics for 2 decades now, and I am a subject matter expert on the VA Innovation Center in bioinformatics, and I also lead some analysis on blockchain and emerging technologies. Thank the panel, and I've listened to pretty much the whole day's meeting, so I think the summit has been very educational, and I appreciate the opportunity to speak about the work that we're doing at the VA. Thank you.
Excellent. And Debbie?
So, hi, my name is Debbie Bucci. I'm now Director of Patient Access and Institutional Data at ConsenSys Health. But I spent my career, I was over 25 years at most of it at NIH and then the Office of National Coordinator. And much of that coming from NIH is very much innovative focus. And while I was at ONC, I focused on a number of innovative challenges that brought the attention of blockchain and other technologies to healthcare. So I have some background about how that evolved.
Excellent. And last but not least, Elaine Johansen. Oh, you're muted.
Is that better?
Yes, outstanding.
Well, as I was introduced, I work for the FDA. I'm the acting director for the Office of Health Informatics within the Office of the Chief Scientist. And our focus is really on solving problems that scientists have with unique and innovative solutions. I'm going to talk to you today a little bit about precisionFDA and about the challenge that we worked on with VHA.
Excellent, excellent. And before we jump into that, Dr. Amanda Purnell, who worked with you on that, is running a data summit at the VA today, so may be able to pop in. Hopefully we can see her and say hello, but if not, there's lots of great work going on in many different places, which is awesome. We are going to go through this exciting challenge and the results in just a moment, and then we're going to jump to a couple of other things. One, a hackathon that we did here at ConsenSys Health with partnership in mentoring and judging with the FDA, or sorry, with the VA, as well as Health and Human Services, and then talk more generally about how innovation can really more seamlessly move through idea into implementation better than it does right now, which obviously we are trying our best in the time of pandemic, but the more innovation we can bring, the more new solutions we have for those problems we've heard about this morning. So with that, Elaine, I will leave it to you to walk us through precisionFDA and what amazing work you did with the VA.
Thank you so much. So thank you for the opportunity to speak with you today about precisionFDA and our collaboration with the VHA. I think Amanda would agree if she was here that this has been a successful endeavor and one that we hope that we can build upon for future challenges. I will begin the presentation with an overview of precisionFDA and the challenge preparation. And I'm hoping that Amanda will follow with a discussion of the data set used, the analysis, and announcement of the winners. But we'll see. I may have to do that myself, so we'll see. Next slide. Yes. Thank you. PrecisionFDA began in 2015 as a research effort to support the development of FDA's regulatory standards in evolving genomic science. It has evolved to focus more broadly on all areas of omics and now offers a globally used scientific collaboration testing and biological data science platform. The PrecisionFDA team coordinates across FDA and with other government agencies to support the FDA mission and the vision and intent of the American Innovation and Competitiveness Act and 21st Century Cures. PrecisionFDA offers a high-performance computing environment and access to a community of experts, a library of tools and applications, a competition framework, and virtual lab workspaces to allow FDA scientists and reviewers to collaborate with external partners. PrecisionFDA is constantly evolving to meet the needs of our stakeholders. Over the next 6 months, we will be expanding the environment to include a virtual desktop capability for our data scientists that will allow them to use ShinyR apps, Python, and Jupyter notebooks in a high-performance computing environment with a look and feel that is similar to their desktop. Next slide. One of the most popular outward-facing features of PrecisionFDA is the challenge framework. This allows biological data challenges to be conducted in a public-facing high-performance computing environment. These challenges focus experts around the world on common problems in areas of evolving science, such as genomics, proteomics, artificial intelligence, etc. The inception of a PrecisionFDA challenge begins with the ideation period, where collaborators meet with the PrecisionFDA team to discuss challenge ideas, goals, incentives, and potential data sets. The data sets are the most important piece of this. Once a solid idea and data sets are identified, the challenge planning organization period commences, where we focus on development of the challenge information site, determination of submission validation and evaluation metrics, and develop the challenge communication plan. Launching a challenge includes leveraging social media and a variety of communications outlets to maximize participation. It is followed by a period of working with participants and testing and refining evaluation algorithms. After announcing the top performers, the real work begins as we begin to look at how to leverage the results that we have achieved in the health environment and begin working on a manuscript. Next slide. Now that you are familiar with PrecisionFDA and the challenge framework, let's turn our attention to the VHA COVID-19 risk factor modeling challenge. This challenge was created to better understand individuals with known risk factors for several medical complications when infected with COVID-19. Pictured on this slide is the visual representation of the process for competitors to provide a valid submission. This is provided in this format for all of our challenges. As you can see, we ask participants to develop machine learning models to predict health outcomes in the veteran population, including COVID-19 status, length of hospitalization, length of ICU stay, ventilation status, and mortality. This challenge received a total of 34 participant submissions. Next slide. And this is here where I would turn to Amanda and she would speak, but she's not here, so I'll take her part for her. So to protect patient identities in this public challenge environment, the data for this challenge consisted of synthetic veteran health records generated by Cynthia Synthetic Population Simulator. A novel Cynthia model was used to develop to simulate synthetic veteran COVID-19 illness. Using this Cynthia enhancement, a new synthetic data set consisting of 147,451 synthetic veteran patients was developed. Approximately 2/3 of the patients in this synthetic data set were identified as COVID-19 positive. Also included in the data set are 16 CSV files containing information about the patients, including their conditions, encounters, medications, observations, and procedures. For the challenge, that data set was split into a training data set consisting of 80% of the patients and a test data set consisting of 20% of the patients. The training set was provided to the participants to enable supervised learning. The test data set was further split by year, with all of 2019 and older data provided to the participants in order to enable predictions on the test patients. The 2020 test patient data was withheld and was used to evaluate the predictions. Next slide. Once submissions were received, the evaluation team evaluated model performance separately for each of the 5 predicted outcomes, which are COVID-19 status, length of hospital stay, length of ICU stay in days, ventilation status, and alive or deceased. An overall ranking of submissions was generated by combining the ranks of model performance across all outcomes. Next slide. So I'd like to congratulate the top performers, Alice Fang of the Harker School in San Francisco, the University of California, San Francisco Pepper team, and the informatics team from Austin, Texas. My sincere thanks to all participants for your hard work and dedication to the mission of this challenge. Next slide. Yay to them. Wouldn't have a challenge without participants and top performers. The results of this challenge offered us several insights around both COVID-19 outcomes and the use of synthetic data sets for predicting these outcomes in a high-risk population. First, COVID-19 status is difficult to predict based on medical history alone. Second, participants' models performed better on patients with more severe health outcomes, such as days in the ICU and ventilation status versus days hospitalized. Finally, by interrogating features used in top-performing models, we found that known risk factors were identified, including age, obesity, and other proxies for poor health status. This informs us that the synthetic data set is a valuable tool and accurately reflected a high-risk population. Now that will be validated in our follow-up activities, but that's what we believe. We may leverage such data sets to gain meaningful insights into COVID-19 health outcomes in the future. As a next step, we plan to test the top-performing models in a real veterans data set provided by the VHA and begin the process of developing a manuscript. So, very exciting. At this point, I have next slide if we would like to open for questions or go straight to the panel. I wasn't sure.
I think we can, leave it open for questions. There haven't been any come in so far, but as they come in, we'll see if we can address them here. Or as I said, with some of the panels, if we have too many questions, which we're getting a lot of great ones and some dialogue, we're going to do a little follow-up that'll be sort of a written dialogue and follow-up that'll give you a chance to share some things as well.
Thank you so much.
Excellent, excellent, and thank you for sharing that. It was a phenomenal way to really advance things quickly. What we've found, and Randall will be able to put up some slides in a moment so we can talk about the hackathon that we had back in April and May, that there's a lot of great people who are looking to help with solutions, but they don't know where, they don't know what data sets to use, they don't know what the solutions look like, and to really be able to partner in the real world with the VA, with those synthetic data sets, that's an amazing way to do it. And so I'm glad the FDA and VA were able to partner on that. I'm sorry Amanda couldn't join us, but you did a splendid job of kind of walking us through both roles. While Randall gets together some of the slides, I'll just start talking about what we did. So ConsenSys Health, as Heather mentioned earlier, launched on March 2nd. And that obviously is a challenging time to launch. We realized immediately we needed to be focused on COVID for not only survival reasons, personally and organizationally, but that's what was needed in the world. So we decided to have a hackathon which brought together. We come from the, you know, a lot of us come from the tech world. I'm a transplant from the government health world, but a lot of the folks at ConsenSys, our parent, have been in the tech world for a long time, and it's a good way to get teams across the world really looking at a problem. And in this case, we didn't specify a problem. We said, hey, how can some of these new technologies like blockchain and AI even help us? So we put together with a lot of different partners here a contest that allowed people to come in and try and solve any problem that they have or that they could see a solution to with respect to the COVID and some of the impacts. We brought together, and Randall, I wonder if you could flip to the last slide first. We brought together a tremendous number of teams, but we also decided, much like yourself, and we didn't have a specific problem set, so we didn't have a specific synthetic data set, but we put them in contact with NIH and some other places where some public ones were. But we brought in mentors, health and life sciences mentors, providers, systems analysts, folks who are researchers, to really let those technology smart folks know what the problems look like in the real world and what solutions needed to look like. And we were able to have over 500 participants with 30 hours of educational sessions. We had 50 mentors from industry as well as government. We had VA, DHA, Health and Human Services, and we also had judges from VA and Health and Human Services to really kind of refine the lens that we were selecting from. And we had participants coming from about 70 different countries. And Randall, if you could step back to the winners so I can mention them briefly before I jump to Jorge and Debbie for a little bit of insight in their experience. So we did have three excellent winners. One looking at decentralized plasma, or seeing how plasma donors and recipients could be matched, and using some of these technologies for that, along with the decentralized supply chain and decentralized pandemic reserve that really looked at the nature of PPE and how data about that could be shared across hospital systems and across government systems to more rapidly facilitate getting those stores or available resources to places where they were in need. So wonderful work by these folks. But in doing so, I think we found some new ways to do some innovation from the industry side. One, we partnered with government where we could, but from the VA, Jorge was one of our mentors, and then Debbie was a mentor and judge. And I want to bounce to them to just get a few reactions from that event and what it was they saw as a value in accelerating innovation from idea at least into the pipeline where it can start to be brought to those levels where it could be considered for enterprise. First, Jorge, if you could give us your thoughts.
Sure, and thank you for the question. Elaine, I want to congratulate you on the work that you did with your team. That is a beautiful example of leading by example, where you have a private sector and the federal agency working collaboratively to solve a very difficult problem. Kudos and all the success going forward.
Thank you.
What I learned with as being a mentor on the hackathon was that, and I had participated in hackathons before, that normally to succeed, you really need a bottom-up innovation in healthcare. You need to really have a multidisciplinary user-led strategy that tackles a specific healthcare problem. Normally in a hackathon, you have some very technical developers and architects. You pair them up with people that actually know their domain space. I always use the example, if you're trying to innovate in surgery and you don't know what a surgical room looks like, it's going to be very difficult for you to get anything done properly. But with this particular hackathon, it really had an enormous amount of stakeholder and expert involvement, which I think is something that you normally don't observe. Normally you have a bunch of technical individuals sort of in the HL7 model trying to solve problems, and then once they're done, they sort of have a sort of a session where they illustrate what they actually did, what they actually coded. In particular, on the COVID-19 hackathon, what I saw was a group of very highly motivated individuals that really would break down the barriers between the technical experts, so the developers and the architects were able to build the innovation technologies, but then you had clinicians and scientists who bring in their deep understanding of the domain to solve a specific clinical problem. in my 20 years in this space, informatics, by and large, is that divider, if you will, that discipline that is in between the people that make the electrons move and the people that you're affecting them. And so to me, it's a perfect example of how you merge these disciplines together in a real, tangible. It was very quick, it was very compressed, it was like, run. But at the same token, that's the nature of hackathons. So I think it's something that needs to be continued. And I am sure, the FDA with their initiatives, they would probably, have some lessons that were very similar to that. Thank you.
Absolutely. I think collaboration is the key, is bringing as many experts to the table as you can to solve these important real world problems. And it's very powerful. I'm very impressed that you had so many participants. I really liked the idea you had about bringing in the mentors, and I'm certainly going to take some ideas from that, because I really like that. Thank you.
Excellent, excellent. Debbie, your thoughts on the experience?
So first I want to say I did spend a lot of time playing with the VA data for the challenge. I was looking at, there was like over 73,000 positive patients and it was really interesting to play with the numbers and some of the insights just as a layman person, database person looking with it. With the hackathon itself, I think what it was really interesting that they were very strong on the technology and dependent on the health IT experience. And because they came from the outside and not necessarily informaticists that we had, there were a lot of creative thinking out of the box that I don't think we would have seen elsewhere that you see in a challenge, because it's not just those that are experts in their fields, but it's also your hobbyists and others that actually bring new innovation and excitement to the whole process that you don't expect.
And they're bringing, I agree, and they're bringing into that new skills that maybe we with our genomics, we're trying to also level the playing field to allow people who had artificial intelligence experience and maybe were more IT focused to sort of get them in that area as well. As you know, genomics, there's a lot of machine learning used in that area. So that I feel that's the same for our challenges.
Right, and also because they're the uniqueness, I think, of the urgency behind the problem, that everybody wanted to help. They wanted to jump in, and you couldn't help but sense the excitement with that.
Absolutely. Competition does it.
Yes.
I wonder if we could jump to sort of thinking more generally, and here I want to step back and have Debbie share an earlier experience with innovation in government that she headed up back in 2016 with Health and Human Services ONC. I think sometimes in the pandemic we've decided, we want to work on innovation and moving it faster, which is outstanding. It's always good if you can do that before you need it. And I think what we can learn from this is having those systems in place would be ideal, but they are sometimes there. Government has been the driver of innovation, and in the world of blockchain and healthcare, it was really sort of like the epicenter of the industry in 2016 when Debbie and her colleagues at Health and Human Services Office of the National Coordinator held a white paper contest and a codathon looking at this new technology that had been all finance and supply chain and saying, hey, what can this do for health? So Debbie, I wonder if you'd give us a little bit of background on that and just sort of how that drove innovation from your perspective, and then we can jump to sort of more broad innovation in government and across industry.
So I was focused on really some efforts that focused on around fire and around patient access and about how, if you go to, how do you get to endpoints and how do you do discovery? And part of that is I attended a conference that's in the West Coast, Silicon Valley, and I had noticed that this is like 2014, 2015, that there were a lot of cryptologists leaning in around this idea around blockchain. And I had, when they were talking to them, I realized that what they were talking about was the way that actually MIT was talking about how could you do research without actually revealing who the end. So I began to collect the dots, went back to HHS and said, you know, have you heard of blockchain? And they're like, block what? So it was clear, it was really early. So this is in a phased approach where we partnered with NIST. So talking about different partners about the emerging of blockchain to see how it may, we looked at it as a research focus. And so at the time when I did the search, healthcare was, you found it in 3 places: Estonia, Denmark, and MIT were the 3 hits that came up. And so we expected 10 or 15 research papers and got over 77. And so we used that as the first stage to drive a workshop, a private-public workshop at NIST. From that, the feedback and the presentations that we got, that in turn, we used some of the top points that we got from those papers, not just the winners, but across, to do a hackathon that around blockchain. So we incrementally, and that was, we partnered with a public-private partnership we did with Center of Democracy. I can't think of the name right now, but it was a 401 that we were, I mean, we're, what, a 501c, is that what it is that you're allowed to partner? So that allowed them to do outreach, which in turn, not only did we have the winners, but then they had the ConsenSys, the big conference that is in New York. They were able to extend to spread the word about it. So it's just that by one small little act within the federal government can be really
transformational.
fun, even though within the federal, and actually bring in participation from researchers and the public sector and private sector to help.
Excellent, excellent. And Jorge, you had some experience with that or visibility on that, and that spawned some of your innovative thinking at the VA. Is that correct?
Correct. And I think Debbie brings a beautiful point that one individual at HHS, prior to her current work, can make a difference. And she did so. She was novel enough to think about a technology that was emerging, to study it, and then to try to refine what the art of the possible was. Had she not done that, you know, for example, I used all of the white papers, and I reviewed all of them prior to the work that I was studying in blockchain, just to get a baseline of what it was that we were talking about. If you don't have individuals that do that, then you do all the legwork, but you have to, you know, HHS, I was a medical officer at CMS, so I have an enormous amount of respect for that agency. You got a lot of talent in that agency that, you know, these are professionals that have spent decades trying to work out these problems. So you should, you know, listen to the guidance, and the fact that Debbie had the intuition to do so, I think, you know, speaks volumes of her desire to improve the department. At the VA, because of that early work that I was aware of, what we did is, you know, we continued to research on blockchain technology but we took some of that early work from NIST that she referenced, which was NIST actually published a very, very good paper on blockchain and its proper use. And so I began to really think hard about that body of work. And in 2011, we were going to do a HIMSS innovation demonstration at the Interoperability Showcase. Now, unfortunately, because HIMSS 20 was canceled, we'll get a second round in 2021, hopefully, to show in the interoperability showcase sort of what is the value statement with this technology. As you guys know, with the Gardner Hyde curve, they promise that this can solve world hunger to baking bread without the yeast. Now, my wife is a great baker, so I know a little bit about yeast. And so we just have to properly put it in its place and then think about the current state of legacy-based systems and then the additive value of a technology that can potentially enable a transformation with the data in the interoperability space. But that is very difficult summit to climb because the industry has been trying to do so for 20, 30 years. So, it's amazing the work that she has done. And, I'm looking forward to continuing to sort of explore this as we move forward.
Excellent, excellent. Thank you. Elaine, the next question to you, and I guess moving a little bit aside from, technology agnostic, blockchain, AI, these things are starting to integrate, whether it's quantum computing or whether it's the thing that we don't know about yet. Sometimes the hardest thing in innovation is figuring out how all the pieces fit, and especially in government, how to do it from an administrative standpoint. A lot of innovative pockets of government will spark things, but then they go out into industry, and until they reach a certain stage, government's hands off for a bit, and it may not be a seamless pipeline, especially in a pandemic type of situation. How and where do you see some of the innovations that you've been doing with precisionFDA, as well as other things you might be thinking about, sort of connecting that whole continuum and making that a faster pipeline in the future, regardless of what the technology or what the advance is?
So I think that's a great question. I think at its core, what we are trying to do with precisionFDA was provide a platform for innovation to be built upon. And initially, that was not our intent, but we began to see the possibilities that we needed something like that we needed something that we could collaborate with people on the outside and on the inside on these emerging areas of science, and have sandbox areas for scientists to work together. One of our big drivers, of course, was the fact that it's very difficult to get these extremely large data sets into the FDA. There's firewalls, there's ticks, there's all kinds of computer equipment and bandwidth limitations that make that difficult. So being able to have something that kind of straddles, that's secure enough that we can have those collaborations, especially in the review space, where we can collaborate externally and have, the meeting of the minds. But I think the biggest challenge, you were talking about how do you make these kinds of things happen when there's a lot of wait and see and a lot of sort of this kind of expectation that, oh, you say this great thing, but we'll see if that really occurs. And I think in our case, we took a chunk and we said, okay, we know we can do this in 6 months. So we did that and we proved it. And then we started to build upon that. And our goal is always to think, what can we do in 6 months to make things better? And the other thing that I think is really important to move things forward very quickly, other than having an area where you can level that playing field and, as Debbie was saying, get some of those people in who aren't normally involved to spark sort of that innovation. That applies to challenges. It also applies to, sandbox areas and collaboration and just making things available to people. There's lots of scientists who have IT skills. There's lots of IT people who have scientific interest. Providing sandbox areas where these people can explore ideas and challenging them is really important. In our case, we're challenged like everybody else when we have an innovative idea of selling it. One of the things that worked for us is internally, like many organizations, FDA is separate mini organizations with their own mandates, their own funds, and so it can be challenging. And one of the things that we did initially was really sort of have an external focus. And that was a little bit unusual and different for our project. By doing that, we got a lot of interest externally in support. on the project. So then when we really started pushing internally and saying, oh, look, we can offer you something you cannot do today, which is something you need. There was a lot of mailing in of hard drives. People, we call the sneaker net, where they're running around with their, their iron keys and trying to get data. So we had to fix that problem, number one. I mean, that wasn't our big driver, but we knew we could, so we did it. And we did it in a secure fashion, and that sort of made us very valuable. And so we were always thinking of what is the next thing we can do to solve the newest and latest problem. Not solve the problem, but put something in place that allows the scientists and people to come together to solve these problems. So that's what we're really trying to do. We have lots of exciting things happening. We're working with another group to bring data in a secure fashion. This is ultimately an environment that we can leverage to do many, many, many things. So we have lots of big plans, and we have, roadmaps into the future, and we're always thinking ahead of what can we do and what can we support for the agency, but also for just the overall community. The community itself can come, somebody who doesn't have access to a high performance computing environment but wants to participate or work, we provide that. And now they can do things that they weren't able to do on their laptop. They can participate in a challenge. We level the playing field so they can participate in a challenge too with an extremely large data set, such as a genomics data set or a proteomics data set, and be successful. So did I answer your question?
You answered it. You answered it and more, and then also set up the next talk in a way, because we're going to be talking about some ways to use data without moving data, and that might be a new solution that could be there. But
I have a lot to say on that. Sorry.
We'll try and get there too as well. But I want to give Jorge a chance to talk about from your VA perspective, beyond the challenge we just spoke about and the involvement you had in our hackathon. What are some of the other pockets of innovation and areas of innovation that you've seen accelerated during this pandemic, for advancing veterans' health, and how has that shifted or changed to bring that acceleration to innovation at the VA?
I think the pandemic clearly has highlighted previous problems with health IT. Interoperability continues to be a problem. It was before the pandemic, and it will continue to be so unless we have a technical solution to the problem. So in many ways, it has not only highlighted, but it also, I think most Americans are very aware that data today could be the difference between life and death in many ways, not just clinically speaking, but also from an epidemiological sort of standpoint and from a proactive view. So, and I oftentimes tell people that patients are not data, right? Patients are, they're humans that are filled with data points, and you need to understand all that data to be able to render proper care. So I wouldn't say that we've all of a sudden, you've seen this huge emergence of telehealth, but the VA has been doing telehealth for a very long time. And as you know, telehealth has limitations because you can enable telehealth for the provision of clinical care in an instance of a pandemic, but it's really difficult to do a physical examination through telehealth. You can do a history very well, but the history and physical, which is the cardinal tenet of a good diagnosis, can only be done properly, usually, by having both a good interrogation clinically and a good physical examination. So there are limitations there, so you can't just innovate for the sake of innovating, hoping that all of a sudden telemedicine is going to solve problems that they weren't meant to solve. And so have I seen, the VA is extremely good. For example, an example of innovations is the ability to codify the terms in COVID. And so we stood up a very quick terminology team that very quickly was able to orchestrate a semantic definitional component so that when we said COVID, the database is understood. And that's critical because having 130 different versions of Vista like we have at the VA, and if we were to have that much variability on just defining what we're speaking about, then imagine trying to do analytics off of that. So, that kind of pioneering work happens at the VA a lot. VA is a nationally recognized leader in health informatics. They have been for 30 years, and they continue to be. They're very modest in how they do their work, but make no mistake that many of us work at the VA because we consider informatically the VA to be probably a national treasure.
Excellent, excellent. Thank you. And we only have 5 minutes left before we jump to the next session. I wonder if both Debbie and Elaine, you both kind of lit up a little bit when I said move data, data without moving it. So why don't we spend just a minute or two each on that, Debbie, and then Elaine and Jorge, if there's time, we'll go back to you as well.
So I guess the one thing that I wanted to say is that FDA already has a presence of creating analytical models and sharing them out. So they're always open and willing to share and learn and take that information back. And with this existing idea that they were able to do analytics and not share PII or information and be able, maybe that is the start of not only bringing in data and sharing out, but maybe this might be a way to open that door into having those models tested elsewhere and more so than build on what they've already done in the past.
So exactly, I think that's great. There's a lot of data model work going on as well, which I think ties to Jorge's terminology. I think we need to get together on that to share some back and forth, certainly. I just wanted to say that I'm very interested in not continuing to move data. You mentioned the movement of data. I would really like to see it so that we, even through the regulatory process, are able to certify environments where we can leave the data where it is, as long as that environment follows these certain rules and is as a regulatory certification of some sort, where we can actually, for precisionFDA, even as part of the regulatory process, leave the data where it is and bring our tools to the data. So our tools for comparing the data, analyzing, et cetera, I would like to see that, because I think as we move data, it gets messier. You may not have the authoritative source of that data. You lose track of it as you move it around. I know that there's a wealth of data at NIH as well as the VA and VHA that is very, very useful. A lot of these people doing these industry doing applications are utilizing some of that data, and when it gets to us, they've added to it that it's changed in some way. So I like the idea of leaving data where it is. I think it's a challenge that we could achieve in the next 5 years. We've all put our heads to it, and I would like to see that for precisionFDA, where we are actually moving our tools to the data versus the data to the tools. I'd like to see that happen in a secure fashion. So,
you're here, yeah. The deployment of decentralized AI and what you can do with the distributed ledger for auditing that and keeping track of what's happening is I think the future, and I think that future has been accelerated by this pandemic. We have a couple of minutes. Jorge, your thoughts on that topic to close us out.
Well, Sean, you can't have a better segue into emerging technologies than what Elaine just alluded to, because trying to move the legacy sort of carriers, not exactly easy to do. And so her approach is a much more nimble approach where, things like distributed ledger technologies actually by design, architecturally in principle, designed to do what she just alluded to. The question is, can you hire enough blockchain developers to actually do the proper, incredibly difficult work that needs to happen, and then show a real world use case that demonstrates the art of the possible. Without that, then it becomes a phenomenally beautiful desired state. But if you can't execute it, then it's just a brilliant idea that kind of dies, in time. And we don't want that. We want to actually be able to see and materialize these innovations so that they actually affect people's lives and improves their lives. So, Elaine, that was a beautiful segue to Sean's next
Great.
panel.
I'm so happy.
Excellent. And I do want to continue this dialogue. I think one point, just to throw it back to one of our earlier sessions when we were talking about veterans and employment, one of the things that it was an early conversation Dave Sutherland and I had from Dixon Center is how can we get transitioning service members to be trained in some of these new emerging areas where there are shortages in knowledge, to make them not only having a career instead of just a job, but also a lot of them come with both security clearances as well as knowledge of the complexities of bureaucracy that will help them navigate federal systems and federal health systems of data in a way that maybe would be more frustrating for people coming from the industry tech world. I think that's something that we're going to continue a dialogue on, and I hope that we were able to bring that to all together. But it really just reminded me of that conversation earlier today. I want to thank you all. This has been a delightful conversation. I want to thank you, Elaine, for giving us the honor of being where you announced the winners of this. I'm sorry you had to do double duty with Amanda. I did hear that from her. She's very busy with the Data Summit, and that's understandable. Maybe she owes you coffee for a virtual coffee. But I hope to continue this dialogue, and we'll see what we can do next.
All right. Thank you so much. Take care.
Excellent.
Thank you.
Thank you.